Okay, good morning. My name is Lisa Hark, and I'm Director of the Glaucoma Research Center, and I'm here to talk to you about the Wills Eye Community Intervention to improve glaucoma detection and follow-up care. I'm going to present the Year 1 results. This program is funded by the Centers for Disease Control, and the principal investigators are Dr. Jay Katz and Dr. Julia Haller, and I am the project director. Before I start, I want to present some of the results from our previous CDC-funded study, which has some very important preliminary results. It was a 2-year study, and it was a demonstration project in order to see whether we could actually go out, identify community partners, and screen and identify and detect glaucoma in the Philadelphia community. We actually ran this program from 2012 to 2014. We partnered with 40 community sites. They included senior centers, senior residents, community centers, health centers, churches, and the YMCA all over Philadelphia. And the purpose of that program, again, which is now complete but has some very important findings, was to identify adults in underserved communities in Philadelphia who are very vulnerable to glaucoma. We conducted educational workshops, usually during lunch in the community setting, and that purpose of those workshops was to increase the awareness of glaucoma and its risks, and also to recruit people into getting this complete eye exam. We performed community-based focused ocular exams, again, complete eye exams to detect glaucoma, and we provided important treatment in the community setting. So we have laser treatment, we provided medications, and we also referred them. And we diagnosed a lot of patients with glaucoma, glaucoma suspect, and narrow angle. So we were able to see between 15 and 20 patients a day. We traveled to the site. We brought the slit lamp. We measured the pressure. We brought the visual field machine using the octopus. And we also did the handheld camera for fundus photos, particularly for people with diabetes. Our recommendations were, if you have glaucoma, we were going to treat you. We would recommend that you get treated with laser, and we would have the laser on the spot for an SLT. If you had narrow angle, we would perform an LPI, laser peripheral iridotomy. We were recommending that anyone that had a laser come back in 4 to 6 weeks and 4 to 6 months. For those who were diagnosed with glaucoma suspect, we recommended they come back in 4 to 6 months. And if they didn't have glaucoma, we referred them to their local eye care provider. We returned to those same sites in 4 to 6 weeks and 4 to 6 months and made it extremely convenient for the patients. So the good news about this project, from January 2013 to May 2014, we were able to examine a total of 1,649 subjects or patients. And many of them were scheduled following the glaucoma awareness workshop. We had 1,500 people who attended this, were scheduled. Many of them showed for their appointment. We made up the difference with walk-ins. So we had almost 600 people walk in same day. It's very important for community programs to accept walk-ins, and we screened 1,649 people. We had very low no-show rates and very low cancellation rates, which is very unique for a program like this. About 70% of the patients were African American. We had 11% Asian, 4% Hispanic, and 14% Caucasian. And the results were absolutely outstanding because we actually detected 715 new cases of either glaucoma, 63 new cases of glaucoma, 352 patients had glaucoma suspect, which was about 20% of the population. Narrow angle, and we had 98 cases had existing glaucoma but were not in care. They were not taking their drops and they were not being followed by an ophthalmologist, but they knew they had glaucoma. So 44% of the 1,649 subjects actually had some type of glaucoma. And this is extraordinarily high. So of those patients, we enrolled 280 into a 1-year follow-up, and again, we're continuing to follow those, and several papers have been published about that. So what I'm going to focus on today, and many of you are participating in this, is the 5-year glaucoma detection study. It's called the Philadelphia Community Intervention to Improve Glaucoma Detection and Follow-Up Care. Dr. Katz, who is a glaucoma specialist, is the PI, along with Dr. Haller, who's a retina specialist, because we're looking at both glaucoma and retina in community settings, and I'm the project director. So we have two phases of this study. Phase 1 is to determine the effectiveness of telemedicine in a community-based intervention using fundus photography of the optic nerve and macula in order to detect previously undiagnosed cases of glaucoma, glaucoma suspect, and other eye diseases such as retinal problems in high-risk population. Once the patients or subjects are enrolled, then we are randomizing them to follow-up care with a local ophthalmologist with or without the help of patient navigators and a social worker. So that's the second aim. In order to be enrolled in the study, you need to have, we're looking for people, a diverse population at risk with previously undiagnosed glaucoma, glaucoma suspect, or other eye diseases. If you're African American, Hispanic, or Asian, and you're over 40, you are able to be eligible for this study. Caucasian, over 65. Any ethnicity, if you have a family history of glaucoma and you're over 40, if you have diabetes and you're over 40, and you need to meet one of those criteria and not be currently followed by an ophthalmologist within the past year. If you're excluded if you have previously diagnosed glaucoma or other eye diseases and are currently being followed by an eye doctor. So we're looking to find new cases, follow new cases, and detect new cases. We are partnering with 17 community sites, all of which have IRB approval. We're working with 7 primary care offices through Temple, physicians. We have Public Health Management Corporation. We have 4 health centers through PHMC. Health Federation of Philadelphia, we have identified 5 health centers, and we also have 1 health center through the Philadelphia Department of Health. Through that, we have about 17,000 eligible patients that are in our database that have been provided by these partners. So the study design is visit 1, visit 2, and then visits 3 to 7. Visit 1, I'm going to walk you through, is we actually do telemedicine. So we have a fundus photo taken in the primary care setting. We're at each site about 2 to 4 days over a period of several months, and we're aiming to recruit 2,500 people or subjects in that. So visit 1 consists of taking pictures of the optic nerve, macula, and anterior segments. We take 2 pictures of the anterior segment, and we take several pictures of the retina and the optic nerve. We're using the handheld camera, which is the Volk new handheld camera. It's very light, non-dilated, and takes about 5 minutes. We can see about 25 patients in about a 4-hour period, and we also check the intraocular pressure using the tonometer. So all of our staff are trained on that. And when the 4 images of each eye are transmitted securely to the Wills Telemedicine Reading Center, our trained readers are all of our glaucoma specialists. They review all of the images, and we also have a trained retina reader reviewing all of the issues about retina. And the reports are generated and they're posted on a secure website, so each of the primary care offices are notified within 1 week that their images have been read and the reports are ready. They download those images and they link them to the patient's electronic medical record in their own system. So each provider has a login. So these are some of the things that we're seeing. So again, non-proliferative diabetic retinopathy. Over here, this is the optic nerve, and these are some of the pictures. This is more related to retina, but you also have large cup to disc ratio, narrow rim, and you can see here some problems here. And then asymmetry, they are not similar, so they're dissimilar. So we will be doing additional training on how to read these images. This is, again, more related to retinal issues and some hemorrhaging going on over here, and then you can see the difference between the large cup to disc ratio amongst all of these and these other problems over here. So this is pretty much what the primary care provider will see on the report. These are some other problems, nerve fiber layer abnormalities, you can see around here. And this is what the pictures look like. This is a sample report, so we'll have the right and left eye. We'll pick the best image and put that on the report. And then over here will be the findings, and down here, and this will be signed by one of the glaucoma specialists. So the primary care offices can download these images, and our role in this process is any patient that's normal, all the patients get a letter with their results. If they're normal, they're recommended to follow up with their own eye care provider, and we also provide them with a list of local eye care providers in their area in case they don't have one. If they're abnormal, we invite them back for visit 2. If they have a poor image or unreadable image, which is common, it's about 10% of our patients that we photograph have unreadable images, they return. They are also invited for visit 2. Sometimes we have urgent pathology. We may see a melanoma or we may see a retinal hemorrhage. They are immediately called and gotten into the system. We also call the primary care provider, and they're responsible for getting in touch with the patient. So once we send the letters back, we call all the patients that have abnormal results or unreadable images, and we personally invite them to come back, and we schedule them for visit 2 for a complete eye exam in that same primary care setting or health center to confirm the diagnosis. We're aiming to schedule at least 600 patients for this, about 25% of this 2,500. At this complete eye exam in the primary care office, which we refer to as visit 2, we are doing a complete ocular and medical history, including medications, ocular history, ocular medications, visual field testing, slit lamp examination by a glaucoma specialist. For the people with diabetes, we may dilate them so that we can have a better view of the retina. Gonioscopy to check the angle. We check in the intraocular pressure with the Goldman apparatus, not the tonometer. The Goldman is the gold standard for checking pressure, which is connected to the slit lamp. And we're checking their corneal thickness with pachymetry, and then we're coming up with a diagnosis and a treatment plan. We're also looking at the original pictures compared to what we're seeing in that confirmation diagnosis. So these are just some pictures. We're bringing the octopus mobile unit to have the patients all get visual field testing. We're doing the complete eye exam and checking the pressure. And we're coming up with a recommended follow-up based on the American Academy of Ophthalmology practice guidelines. If they do not have glaucoma and they have normal eye exam, they should follow up every 12 months. If they have glaucoma suspect, we're recommending that they come back in 6 months. And if they have glaucoma, they need to be followed every 3 to 4 months. If they have narrow angle, then every 6 months. And then if they have ocular hypertension, they should come back every 6 months. Some people have a normal eye exam and they have a normal disc and they have a normal looking retina and everything's normal, but they have high IOP. That's called ocular hypertension, and they do need to be followed. If they have diabetic retinopathy, of course, it depends on the severity, anywhere between 1 to 2 months. If they have advanced stage of DR, or if they have mild DR with no diabetic retinopathy or mild, they may need to come back once a year. If they have macular degeneration, again, it depends on the severity, and we refer them to the retina. We are finding several cases of visually significant cataract, particularly in the patients that had unreadable images, and we are recommending them for cataract surgery. So once they complete visit 2, we tell them right then what their diagnosis is and what their issues are, and we figure out where they live and whether they want to enroll in the study, and we explain to them that the study will be following them for 2 to 3 years out from visit 2, and they need to be seen by the local ophthalmologist in their area. And we are randomizing them once they enroll to one of 2 groups. Group 1 is the intervention group, and they will be having the assistance of a patient navigator and a social worker to help them with making the appointments, scheduling the appointments, and discussing various other social issues. The other group is usual care, and they are referred to the local ophthalmologist. They are now allowed to select the ophthalmologist of their choice, so we're randomizing by patient, not by site. So one site could have patients who are enrolled in group 1, and the same site could have patients enrolled in group 2, and that's in the best interest of the patient. So once they get referred to the local ophthalmologist, they are also doing a complete eye exam. And that visit is scheduled within 8 weeks of visit 2. And like I said, they select from the available list, and we are, each office will be referred about 10 patients. So all the local ophthalmologists are sent a copy of Visit 2 report, which includes the diagnosis and severity and the treatment options that we recommend, whether it was laser or surgery or drops, and what our recommended follow-up is. And the patient is also given a copy of the report. In Group 1, we actually help them schedule Visit 3. We help them at the time of the visit or within the next couple of weeks, we actually help them schedule the appointment. So like I said, the staff schedules Visit 3 for all the patients enrolled in Group 1. We're looking to enroll 150 subjects. That we also remind the patient, as well as whatever the office procedures are in terms of reminding the patient. And we also help them if they need any assistance with insurance issues or getting assistance with medications. Whatever they need, the social worker and the patient navigators are helping them over the next 3 years. The social worker assists with navigating the health system, contacting the insurance providers. If someone doesn't have insurance and they need help getting on insurance, we help them. We help them with scheduling. And like I said, we help with providing transportation, assisting with setting them up for all of that. And we also assess their functional status and other emotional issues as needed, which are barriers to getting into eye care. The usual care group, again, we only schedule the patients, and whatever the office procedures are, so many of the offices call the patient the day before or they send reminder letters. That's usual care, and that's standard of care. So that's the comparison group. Okay, and whatever the methods of surgical coordination, or if that office picks patients up to take them to their appointments, whatever that usual care is, that's in place. So our preliminary results from April 6, 2015 to May 19, 2016, we have had 738 subjects consented and screened for Visit 1. That's the telemedicine visit. 300 of them have been walk-ins and 436 have been scheduled. And this is important because the ones who were scheduled, remember, got letters and got phone calls. And there were thousands of letters that went out, so that cost in terms of postage. There were over 8,000 calls made by our staff to remind the patients to come in and to schedule them. So if walk-ins are providing just as much contribution, then maybe we can save a lot of money if we don't schedule and we just do walk-ins. So that's why we're very interested in comparing the walk-ins with the scheduled. Of those 738 subjects, 264 have been diagnosed with abnormal findings. 46 have normal findings but high IOP, so that would be ocular hypertension. 121 have unreadable images. 307 have normal findings. So I'm going to walk you through some of the specific results. Of these 738 who have attended Visit 1, again, 264 have abnormal findings and 217 have actually come back to attend Visit 2, which is very good. And of those, 135 have diabetes. Now, at the present time, after 1 year, we have 185 subjects enrolled and randomized to Visit 3, and we're aiming to reach 300 total, 150 in each group. So these are just some of the results in terms of patients consented and screened versus walk-ins versus scheduled, and I just showed you those data. And then in terms of abnormal findings, the ones who were scheduled had more abnormal findings. I'm not sure if this is statistically significant, but it's interesting because those people may have had symptoms. They have maybe had some symptoms of eye problems or eye blurry vision or seeing double or some abnormal findings, and more likely to schedule that appointment and keep that appointment versus walk-ins. So more abnormal findings in the scheduled, and then patients with unreadable images also had more abnormal images or unreadable images. And again, that may be because they have some vision changes, such as cataract problems. So this is just a breakdown in terms of normal, abnormal, and unreadable. So if you combine the unreadable, if you combine all of this, it's about 58% are invited back for Visit 2, which is a huge number. Even 37% having diagnosed abnormal images is a very high number, okay? So the reason why it's so high is because the doctors, not only are we dealing with a high-risk population, but the physicians have a lot of clinical data. They have the IOP, they have the age, they have the ethnicity, whether the patient has a family history of glaucoma. Okay, so by having all of that clinical data, when they're looking at the picture and the optic nerve, they are more likely to be able to predict accurately that the patient actually has an ocular diagnosis. So our results for visit 1, again, just specifically, 241 patients have specifically either glaucoma or glaucoma suspect. And these are all new cases of patients that are out there and not being followed. 57 cases of diabetic retinopathy, 57 cases of other retinal abnormalities such as macular edema or other macular problems not specifically related to diabetic retinopathy, 121 unreadable images, and 307 normal subjects. So this is a very large number. All of these need to be followed. In terms of the specific diagnosis of what is happening on visit 2, 264 patients have returned for visit 2, and again, we are confirming we have 153 cases of glaucoma and glaucoma suspect. We have, again, continued to have ocular hypertension, diabetic retinopathy, other retinal abnormalities, and 17 subjects have been diagnosed with visually significant cataract, meaning they need cataract surgery. They're coming in at 4+ on their cataract diagnosis. So we are getting them help with that. And then we have 144 subjects that have other pathology. You notice this number totals more than 264 because many people have glaucoma or glaucoma suspect and some other pathology. Okay? So this is a very large number as well. So in terms of patient satisfaction survey at visit 1, we have surveying all of the patients at the end of visit 1. This is very important when you're doing any community outreach or any kind of research study. We built in satisfaction surveys. We ask them, how likely are you to return to this location for your complete eye exam? And 94% said that they would return. So the convenience is very, very important to them. How likely would you be to recommend the screening to a friend or family? And again, this was after they had the telemedicine, 82%, and then 80% said that it was very convenient to have the screening in their office. So very high numbers and very high chance that the patients will continue to participate. We're also doing a cost analysis, which is very important because this program, this research program is costly and expensive, but we believe that we can show that with all of the new cases that we're detecting and treating and managing and following, that it can be cost effective. So we are measuring the cost effectiveness and we're identifying where the program cost can be minimized. And we're looking at this over 2 years. Our cost measures are human cost, which is staff time, non-human cost, which is all of the price of the medical equipment, the supplies, the community partner recruitment, all of the in-house computers and internet hotspots, the van costs, we lease the van, and also all of the insurance and fuel and miles to take the program out to the community. And we're looking at the adherence to follow-up visit, which is, of course, visit 1, 2, and 3, and we're tracking all of this through patient surveys. So we will have a lot of very interesting data coming out in the next 3 to 4 years. We're publishing our methods paper, which includes year 1 results, and we're publishing many other papers about the inter-rater reliability of visit 1 versus visit 2. We're going to be publishing our results about what is visit 3, and we look forward to sharing the data with you in the future. Thank you.